All right, we'll go ahead and get started. Thank you all so much for joining us today. My name is Cecilia. I'm the co-founder and chief strategy officer here at CareMessage. And co-presenting with me today is Rhea. She is our senior user researcher, and she led a very important project for us this year on understanding SDOH access amongst low-income populations. And today we'll be sharing some of our findings as well as some recommendations. So on our agenda for today, I'll share a little bit about CareMessage, our health equity framework. Then I'll hand it off to Rhea for her to walk you through some of her findings in terms of the way that low-income populations access SDOH resources. You'll be hearing from some of the participants of our research study. She'll summarize our findings and share some action items, and then we'll wrap up with some Q&A. During the presentation, feel free to add your questions into the Q&A section at any time or drop them into the chat, and we'll try to get through those at the end of the presentation. We will be recording this and sharing the recording after the presentation, as well as sending out a summary PDF document with the full findings from our study, so you can read in more detail about our research project and our methodology, as well as the findings. So for those of you, I think the majority of you, there are a large portion of you that are familiar with CareMessage, and some of you that are not. CareMessage was really created around this large problem that we have within the United States. Our healthcare system, we outspend on healthcare, but we have worse outcomes than a lot of other developed nations. And within that, you'll find that historically marginalized communities and low-income communities are being left behind. A lot of new technologies have been developed, and although you'd expect to see technology hopefully help improve health equity, in a lot of ways, technology has widened the digital divide. And so CareMessage was really created around this idea that there's a different way for us to approach the creation of technology and the way that technology can be leveraged to improve health equity. And so CareMessage as an organization, we are a nonprofit healthcare technology organization, and we're really trying to build technology that improves health equity and doing it in a new type of way, really core to who we are as an organization, as a technology organization, trying to leverage technology for health equity and really designing to benefit low-income, historically marginalized communities and the way that they can benefit from tech-based solutions to really combat this long-standing healthcare inequities. As an organization, we are also a very experience-led design organization. We try to bring a lot of our personal lived experiences to the way that we drive change, and we believe that that's very critical for the design, especially of technology, to have those lived experiences help inform the design of solutions. And lastly, as I mentioned, we're a nonprofit organization, and that really allows us to, as much as we generate revenue, apply any revenue that we generate back into driving impact. A lot of that helps us really continue to drive the growth of CareMessage as an organization, but bring our technology to a variety of safety net organizations across the United States. Our vision is really a world where people from low-income communities can achieve health equity through three pillars, which are increasing access to care, improving clinical outcomes, and addressing social drivers of health. And our mission is to leverage technology to improve health equity for people from low-income communities. So I'll be talking a little bit about our new health equity framework. This is the way that we're defining health equity to really drive our organization's impact measurement. We have a big focus on ensuring that our product is actually driving improvements in clinical outcomes. And although we have a variety of technologies and we measure a lot of things like messages sent and engagement with patients, ultimately what we're here for is to really impact health equity. And our new framework is really the way that we're setting and raising the bar for how we believe healthcare technology should be measured in terms of the way that it impacts improvements in health equity and outcomes. And so our goal as an organization is that by 2028, CareMessage will be improving health equity for 5 million people annually. And that's going to be measured on things that are tied to increasing access to care, primarily through tracking the availability, affordability, delivery, and quality of care that's delivered to these populations. The second is around improvement in clinical outcomes and really looking at the journey when we start with prevention, screening rates, incidence rates, and ultimately mortality rates for conditions that we know disproportionately affect our target populations. And the last is our ability to address social drivers of health and really transform the way that we think about the social needs that these populations have through looking at increasing the number of screenings and the timeliness of screenings, improving the distribution of resources, and ultimately ensuring that we're delivering support to patients in need that impact their health. And we see these three things sort of working together or working in tandem to really improve health equity and what we believe to be that opportunity for us to give all people a fair chance to be healthy. And today we're going to be focusing on research that's really defining our approach around social drivers of health. This is really an area that is really important to us as an organization, but going back to our approach on having that experience-led approach to the work that we do, as Ray and I were defining the research question for this study, I actually pulled from some of my personal lived experiences. I have a background very similar to the patients that receive care at safety net organizations. My family relied on food stamps, on Medicaid for a lot of our services when I was growing up. And one memory in particular that I thought about when we were preparing for this research was the fact that every holiday season, my parents would actually go to our local pawn shop and pawn our TV for us to be able to afford to go visit my grandmother in Mexico. And it was this constant balancing of resources, balancing of money in and money to be spent. And it's that constant, rebalancing and that cognitive load of managing that is so critical to experiences that the patients we aim to serve have even today. And so this research project was really trying to get at how do we understand that? Because even though that's the experience I had growing up, it's not the experience I have today. And so it was important to us to really get back to the root of understanding how these problems look like from the patient perspective, and bring that new, hopefully some new insights into the way that we approach social drivers of health. And so with that, I am going to be handing it off to Rhea to kick us off and walk us through her research and findings.
Thank you, Cecilia. Hi, everyone. My name is Rhea. I'm the user researcher here, and I run research projects with our patients and customers to ensure that our work really aligns with our mission to improve health equity for people from low-income communities. So what I'll be talking about today is a project that I worked on for about 2 months, where I interviewed some of our patients from our customers to understand what is the path that they have to take in order to access different types of non-medical resources in their lives. And we really put in a lot of effort here to hear directly from our patients, because the hypothesis was that a lot of their SDOH navigation was happening outside of the clinic. So our clinic staff may be experts in their medical needs, but maybe don't have the full picture about their non-medical needs. And that hypothesis later on turns out to be true because in interviews with 9 patients, only 1 person had talked to their doctor about their social drivers of health needs. Initially, this project was meant to just inform CareMessage strategy, but we now feel like it's helpful to share with the broader community. So I have 2 goals for today's presentation. The first one is to build empathy and understanding about how these interview participants and our patients are navigating their SDOH needs. And the second is to recommend some strategies for how your organization can increase access to SDOH resources. So I ran a series of qualitative interviews with our patients, and the 2 goals were first, to understand how do people of low socioeconomic status meet their SDOH needs when money is tight. And then we also wanted to understand how are these patients and members finding out about these resources in the first place? And why is it that some people choose to engage or participate with these resources while others don't? And these questions are focused around SDOH, but in my interviews with patients, I didn't actually use the word SDOH because I wanted the interview script to be more accessible. The hypothesis here was that SDOH is really a function of money when it comes to the day-to-day. Because you don't have enough money, you might not be able to afford food or clothes or transportation. So really in my interviews, I was asking them to tell their stories about their experiences living day to day in financial hardship. So our participants are individuals of low socioeconomic status who have experienced financial hardship. It didn't matter whether or not they've actually had experience receiving SDOH resources, because I wanted to understand for the people who maybe never asked for help, why that is. And we recruited these patients and members from our customers. Most were English speaking. We had one Spanish speaker. So 3 of the participants are patients of a federally qualified health center in Reading, Pennsylvania. And another 6 of them are members of a community-based organization called Brother Bills that's based in Dallas, Texas. Through the rest of this interview, I will be using the terms members and patients interchangeably, but overall, I just mean the community that is in need of or seeking SDOH resources. Okay, so let's take some time to meet some of our participants. In the later slides, you'll see some initials, and those are the codes that we used for each participant for their privacy. And you will hear some audio clips as well. And then only 2 patients out of the 9 were comfortable sharing their audio. But the insights that I will share on the slides are synthesized from my interviews with all of the patients.
Very reliable person, born and raised Dallas, Texas. I would go to Brother Bill's for food pantry, and I've been there also for some trying to get rental assistance.
I have 2 children. My oldest is 22. My youngest is 14. My relationship with Brother Bills was I just researched extra assistance as far as with food, and I ended up finding.
So now that we get a sense of who they are, let's take a look at what their day-to-day lives look like. For most of these participants, their income comes from full-time or part-time jobs. They might also be receiving cash benefits from different government safety net programs. So this might look like Social Security benefits or a job placement programs funded by the government, or benefits that they receive from the Veterans Affairs Office. They might also be taking on different gigs, such as driving for Uber or Lyft or DoorDash. As for their expenses, the main ones were typically rent, utilities, and that includes water, electricity, heat, and gas. It also includes food and cell phone bills. A lot of times, their cell phones were the only way they have to access internet at home. They also need to pay for transportation, and this applies whether they're paying for public transportation, in which case they need to be accounting for all the different types of transportation that they might need to transfer to in order to get to their destination. Or if they have private transportation, then they may need to be paying monthly loans for their car. And then lastly, storage is one that came up multiple times, where if someone or their family was living with a friend or another family member, then they had to pay monthly storage fees so to keep the rest of their stuff in another storage location. So in this clip, I had asked the participant about what his priorities are for paying bills when he realizes that he doesn't have enough money to pay for everything. In our prior conversation, he had mentioned that 2 of his main expenses other than rent are his car lease and his phone bills, and I asked him which one is more important to him.
Car lease. It's more important because there is public transportation, but it's time consuming, and it's cheaper than, I guess, your own vehicle with the gas, but I think it's more time consuming, like Uber, Lyft, or public transportation. So I think it's more important for the car.
He goes on to say that even without a car, he could get to baby appointments, he can still deliver stuff, but it's going to be much more stressful and time consuming. So I think what this clip shows us is that even if there are technically other options available, they might not always be viable for our patients. In this case, public transportation technically exists, but it's not practical for him. And this kind of prioritization that he has to do is an example of the mental load that people experience in poverty. What I mean by that is I'm referring to the research that has come out of multiple institutions like the National Institute of Health, MIT, and Harvard. And what they all tell us is that when a person is in the state of poverty, their cognitive function is diminished by the all-consuming effects of coping with the immediate effects of having little money. And this means that they are left with fewer mental resources to focus on complicated and indirectly related matters like education, job training, and managing their time. This matters because later on, as we get into the details of what they need to do to navigate this journey, you'll see that so many things need to go exactly right in order for someone to finally make it to that last stage of accessing resources. And it is really difficult to make the best decisions and have things go exactly right when you are just in survival mode all of the time. So let's dive in what the path to accessing SDOH resources looks like. I have broken it down into 4 stages. First, being in financial hardship, and then discovering a resource or somehow knowing that it exists. And then you contact the resource or you apply for the resource. And then lastly, finally, you get to that last stage of accessing the resource. I've presented it here as a linear process, but in reality, it is quite nonlinear, and you can be moving forward or backwards at any point in this journey. It's also possible that one person may be trying to pursue multiple resources, and for each resource, they are at a different stage of the path. So let's look at the very first stage. What are the changes in circumstances that leads to financial hardship? I call these trigger events, and examples of this could be a loss or a drop of income. For example, maybe someone switched jobs or they had their shifts cut off. Someone might have also lost their benefits. One person told me that she lost her SNAP benefits after she was laid off because she had started receiving unemployment benefits, and that made her ineligible for SNAP. Someone might also experience an accident, like their car was stolen, or maybe they need money to buy a funeral dress for someone in their family. Someone might have experienced disability, and this can be either a temporary disability or a long-term one that impacts your ability to work. And then lastly, there's always the poverty cycle. And you have generations that are just stuck in poverty because of self-reinforcing mechanisms. Because you don't have money, you don't have a car, and because you don't have a car, you can't go to work. Because you can't go to work, then you don't have money, and the whole thing just continues. You'll see here the quote on the right, "I'm hoping and praying that I keep this position." This participant was talking about a job that she had gotten from her state's job placement program. And she is so desperate to keep this job because this job was the only thing that was keeping her from being in financial hardship. So the first thing that people do when they find themselves in these situations is actually to start with self-mitigation strategies. And these are different ways that they try to either save money or make more money. This might look like changing eating habits. Maybe you don't eat out with friends anymore and you decide to cook more. Maybe you delay your bills. Either you negotiate directly with, let's say, the utility company to extend your bill, or you just choose to not pay it that cycle. Multiple people also mentioned donating blood and plasma for money. There was one person in particular who said that he donates plasma regularly and he believes that it is bad for his body, but he continues to do it because it gives his family financial income. People also cited spirituality, and I put spirituality in here because we know that being in poverty has a big physical and emotional toll. And for a lot of people, spirituality is what helps them face the emotional toll. So this quote here on the right, pretty much I budget and try to do what I can. I'll change where I shop, how I shop for necessities like toiletries and things. So there's all of these big or small changes that participants try to make in order to pull themselves out of this situation. And another one of these strategies is gigs. So people might be taking up extra shifts on Uber or DoorDash or Lyft or taking on different side jobs. I want to talk a little bit more about the side jobs that people take on, because sometimes they actually have the opposite effect. One participant was telling me that she was always doing a lot of other things to make more money for her family because their family was constantly in emergency mode. So she told me that over the past years, she has sold jewelry and Avon and Melaleuca, and all of the companies that she listed are multi-level marketing companies. Typically, when you're in an MLM, you are not making money, you actually lose money. So I asked her how much profit has she actually made over the years? And she told me that she didn't know because anytime money came in, it immediately went to paying for something urgent. So with these gigs, you might be losing money, but you don't even realize it because you don't have any time to track the revenue or the profit. So that's looking at how people fall into situations of financial hardship. The second step is around how people find out that an SDOH resource exists. But first, what are the different types of resources that exist out there? There are moms and different family members. Moms especially is called out a lot of times, and they can help with financial support or offering a place to live. We also have community-based organizations or churches that often offer a variety of services. Brother Bills, for example, one of our customers whose patients participated in our research, they primarily offer groceries, but they also have other social services to help with rent. We also have government safety net programs. This could be either TANF for cash support or SNAP for food support. People also mentioned their community. People mentioned the Facebook groups that they have per neighborhood for free items. And one person said that he checks that group regularly to get supplies or strollers for his baby. And then lastly, the Veterans Affairs Office also offers different resources. This quote here, I would try to find some side jobs. If I have to, sometimes I would borrow a little cash from my relative or family member. So participants always try to start by some sort of self-mitigation strategy before they start reaching out for external help. We'll see a couple of these diagrams throughout the presentation. And what you see on the left, that is the previous step. And then on the right, discover resource, that is the current stage that we're talking about. And then on the top, these catalysts, these are the good things that helps someone get to the next stage of this process. Versus on the bottom, you have blockers. These are the obstacles that deter someone from moving forward and therefore blocks them from accessing that resource ultimately. So what are the things that help people discover different types of SDOH resources? First, you have the internet. People have found resources in their lives through Google or from ads in their Facebook feed, or maybe from email information. You also have moms again and other family members. Family members are often a rich source of information, and sometimes they proactively offer information to you without you even asking for it. You also have community knowledge. One participant mentioned that her landlord was actually the one who gave her a list of rent support programs when her landlord realized that she was having trouble paying her rent. Among friend circles, maybe you're chatting in the grocery store. These are all different ways that someone might hear about the available resources in their community. You could also hear about a resource because you were referred by another SDOH resource. For example, maybe you go to a food bank and it turns out the food bank doesn't serve your zip code specifically, but they will guide you to another food bank that does serve your zip code. And these types of referrals also include referrals from their medical offices. But in our interviews, only one participant had mentioned that they discovered a resource through their doctor's office. Lastly, you can also find something because of physical proximity. There was one person who discovered a resource program in a building that had a flyer, and she was in the building because it was where she was going to pick up her child from the Head Start program. And when it comes to blockers, you see the internet here once again. The internet can be a double-edged sword, where if you know how to navigate it well, it has so much information to guide you to where you need to go. But at the same time, it can be so overwhelming and you don't know what to make of all of the different types of information that you're being given. This is especially true if you have recently moved to a new location and you realized that the systems that you might have been used to receiving in a prior state are now completely different in this state, and you just have no idea where to start. I was talking to a participant who had recently moved, and I had asked her about where had she thought to look for help, or maybe what is she aware about the programs that are available. And she just kept telling me, I don't know. And everything was so overwhelming to her, and she didn't even know where to get started. And then lastly, there's stigma. Stigma will show up multiple times throughout this journey. And stigma is never explicitly mentioned in our interviews, but every single one of these participants told me that they had tried to do everything else on their own before they started looking for outside resources. In this clip, I had asked the participant about what is the first thing she does when she realizes that she needs help to pay for everything. I asked her about where she goes to seek help.
The first place, of course, was the North Texas Food Bank. That was the first one. But then I found other places that were associated with them, and that's how I ended up finding Brother Bill.
How did you hear about the North Texas Food Bank?
Through life, growing up, it was just another place where everybody went to go get assistance. So that's how I ended up finding out about them.
In this case, the North Texas Food Bank is just something that she had always heard of before. And for her, it immediately comes to mind as a place that she can go that can help her. And this shows us that participants in these programs are not just passive receivers. They can also be active agents that spread awareness about these programs to other people in their lives or in their networks. The next stage we have is contacting a resource. And this could mean initiating some sort of communication or sending out an application. Sometimes even this step is really hard to get to. And what would motivate you to take this step is if you have trust in other people's experiences. Maybe you have a friend or a relative or a spouse who has used this resource before and recommended it to you and told you that this is worth applying for. Or maybe, especially if you're searching online, you have trust in the legitimacy of the source that's telling you that, okay, this address is real, so I'm going to get in my car and actually try to go there. Maybe you've had prior experience with this resource. And lastly, these resources have to be accessible. So either it's accessible physically and you can get there, or you're able to contact them on the phone or online. And some blockers are lack of transportation. One person had told me that he knew about a resource that was just down the street, but because it was too far to walk to, and he needs a damn private jet to get there, he chose to not go. Sometimes the resource that you've used before is terminated, or its rules say that it's a one-time use, so you can't go back again. And then lastly, you have stigma. Stigma is both societal and internal, and it is oftentimes self-contradictory. One person went so far as to say that he would eat baking soda if he had to, instead of trying to look for extra food externally. But he also said that if he could tell other people one thing, it's that it's okay for them to ask for help. In this video, the participant had told me that he has found different resources through Google, and I asked him, among the list, how does he know which ones are the right ones?
Well, I guess it's I see what the word of source, where it's coming from, what source it is. Because if it's like NBC5 News, something like that, that's a legitimate source, and then I'll kind of go with it. But
So in this case, because it is a local news site that he knows and trusts, he knew that it was something worth pursuing and checking out. The next stage, finally, if you are able to jump through all of the hurdles before, is accessing the resource. And this means receiving the food or maybe receiving clothing that actually meets your needs or at least reduces the severity of your need for these different non-medical items. What helps you get there is, first of all, an easy application process. And when I say easy, I mean it's simple in terms of how long it takes and also how complicated it is. It might be useful to consider having an application that someone can complete in 2 sittings, because one person told me that she started a food bank application when she was there, but something came up and she went home, but she was able to finish the application at home. Also, having concise requirements is really helpful here. Don't require obscure documents, so stick to standard IDs, maybe utility bills. This way that you won't be having people who are unable to apply just because you're not able to find these specific documents. Providing transportation or having access to transportation always helps. And then lastly, having a warm reception. And I don't think being nice is the deal breaker for someone when they are looking for a food bank. But nice is the word that comes up repeatedly when people describe the resources that they really value in their lives and the ones that they go back to again and again and that they would recommend to other people. Some blockers to access include an application black hole. Maybe you applied for a program and then you just never heard back and you don't know why. Sometimes people have trouble completing the application. one participant told me that their SNAP application required them to put down an address. But at the time, their family was staying with a friend and they didn't want to use their friend's address on the application. So because they didn't have a permanent address, he ended up not being able to complete the application. In other cases, you might find out that you are ineligible. Maybe your zip code is not in the service area, or your income level is considered too high, even if it's still not enough. Or you find that your child can't be included because of their age. Maybe you passed the deadline to renew, or the renewal process was too complicated and you just expired out of the program. And then lastly, there's the mentality of someone needs it more. When I was doing recruiting for this project, I was talking to staff at a lot of different clinics. And I talked to Jordan, who is the senior manager of population health at Access Health, that's based in Florida. And she had told me that their clinic started doing food RX, which is food as medicine, post-COVID because the grocery prices in their area was getting so high. But they found that their patients were not coming in to their scheduled pickups. And they thought it was a transportation issue, so they sent out cars to pick people up. But still, uptake was very low. So they talked directly to the patients and asked them why. And the patients said that they didn't want to pick up the grocery items because they thought someone else needs it more. And so they don't want to take it away from those patients. So this tells us that if you talk to your patients, they'll give you a lot of insights. And a lot of times the reason for their behavior might be different from what you assume. So in that video, I had essentially asked the participant about her experience applying for benefits. And she had said that she does a lot of research because she needs a lot of different types of benefits. And there was one time where she found this food bank in her city, and so she went, but then she found out that her zip code is actually not in the service area for the food bank. And this tends to happen especially in bigger cities. So for her, she went to some place called the Houston Food Bank, but it turns out because her zip code is not considered sort of high need within Houston, she's not eligible to receive those services, even though she technically lives in the city of Houston. So it's all of these small things like this that can get people caught up and make it really hard to complete that final step of actually getting what you need. Yeah, so there's a lot of obstacles and there's a lot of challenges to getting it right. But when an organization does successfully meet someone's needs, the impact is really huge. So this participant had said that she recommends her community org to all the other people in her life. And I asked her about how does that conversation even come up in the first place?
Like if I'm in out in public and like we're in line or something and we'll just be, just talking and then someone to say something in a comment or something like that, and I'll be like, oh, well, I know of this such and such company that assists in these certain things, and they'll be like, oh, well, you mind give me that information, and I'll pass it over to them or whatnot.
So these stories are pretty common. Another person mentioned that there was like a sales associate in a gym that was trying to sell her a membership, but somehow they got to talking and she ended up giving the information of the clinic or the place that she goes to for help to him. And that was how he found out about it. So one good experience with one person really helps create this positive loop where it makes it more okay to openly discuss the resources that you're receiving and also treat these types of organizations as an established and trusted pillar within the community. And once someone is able to navigate this journey once, they are so much more likely to be able to do it again or to help another person do that journey for themselves.
Being like if I'm in
So before we summarize this journey, I wanted to share some things that I heard from the participants about their opinions when it comes to their journey to access. First, I asked them about how they would like to hear about the resources that are available to them. And it turns out that there really wasn't much of a difference between email or texts or phone calls, because it didn't really matter to them what format they got it in. They just cared that they had the information in the first place. Some people suggested maybe receiving a physical flyer, or they wanted more of a social worker service, where a social worker would go into their home and figure out what their needs are on a personal basis. So even though there's all of these methods for electronic communication, for some people, they still really value that human and in-person touch. I also asked participants if they had a magic wand, what service or resource would help you the most in daily life? Some people mentioned financial support. Some people mentioned removing zip code restrictions on resources in their area. And someone else wanted help navigating resources because they had received a big book of resources from their Department of Social Services, but the book was so long that they didn't even know where to start. For other people, having mental or spiritual support is really great. And other people wanted faster clinic operations so that they can get in touch with the clinic staff. You have this quote here. It's not so much of finding the program, it's just the process that sometimes you have to go through in order to get approved. I think that's the hardest thing. So to summarize, if we go back to our original interview goals, we have learned that low-income populations meet their SDOH needs through self-mitigation strategies, reaching out to their families and friends, and applying for different aid programs through public and private organizations. And as they are doing this, they are considering all of the trade-offs of juggling their short-term needs and their long-term needs, such as choosing to pay for rent versus choosing to pay for food. We also learned that patients and members find out about SDOH programs through community word of mouth, through their family, online search, referrals from other SDOH programs, and also physical proximity. And they choose to participate in these programs based on the transportation access, the trust they have in the organization, how easy the application process is, and the service experience that they receive. So here is the full path in full. We have gone through all of these 4 steps, and for each step, we've examined what are the catalysts that helps someone progress versus the blockers that hinders someone from moving forward. Now that we've looked at the whole process, in order to make this process easier for our patients, we would need to intervene at different points in this process and either strengthen the catalysts or remove the barriers. So here are some suggestions, along with some real examples taken from CareMessage customers about what you can do to open up access. First, we suggest publicizing your resources. Multiple participants did not know about the full range of resources that their either CBO or their FQHC offered. And they might have just been used to receiving, let's say, just groceries, and they've been there for years. And they never knew that that organization can also help them with their rent. So publicize your full range of services to existing clients, but also potential clients. You can do this through text, online, or do it in person, any way you want, as long as it's out there. This example on the left here, the patients are being invited to a workshop where they will receive a free gift if they make it. Another recommendation is to get creative about the ways that you can meet patients where they're at. Maybe you come up with a way of delivering resources directly to their home, like this example on the left, or you provide transportation or organize some sort of carpool so that everyone is able to get to where they need to be. We also recommend taking a digital-first approach to resources. A lot of times when we think about SDOH resources, we think about brick and mortar organizations. But there are actually tech nonprofits with a digital presence that can support patients in different ways. And in a later slide, Cecilia will talk through some of these digital resources like websites or hotlines or apps. Other suggestions here, you can encourage your community members to refer other people. Word of mouth was the most common method that came up in our interviews, and it has long-term benefits because if you tell one person, you don't know what are all the other people that they could tell down the line. Also, address stigma and scarcity mentality directly. I have heard people say, I'm a man, so I don't ask for help, or I don't want to take this away from someone else. So understanding what are the blockers for patients, both physically and mentally, can help you better help them receive the resources that they need. Also consider reviewing and simplifying your application process. Really look at all of the steps that we require and the documents that we require to see if you are maybe unnecessarily screening out people who might actually qualify and be in the target audience that you're trying to help. And then lastly, consider seasonal needs when you're offering resources and check in with your patients. One participant told me that her priorities for bills actually varies by the season, because in the winter, she prioritizes paying for her utility bills because she has to have gas for the heater, versus in the summer, she can prioritize other types of bills. So now Cecilia is going to talk about some of the digital resources that you can offer your patients, regardless of where you or they are located.
We try to put together a few things that we've both seen from our customers in terms of things that they're doing in an innovative way, but also those that we know of. Prescription for Play from the Lego Foundation is one that at least one of our customers is using, and essentially you're able to sign up online and get small Lego kits that can be provided during pediatric appointments to your pediatric patients. The second, those of you that are federally qualified health centers, and if you attended the NAC CHI conference, you might have seen, it was maybe Albert and Bernie on stage with Dr. Ree. But Sesame Workshop has developed a variety of resources, and you can sign up online as well as request physical books that you can put in your waiting room and provide those to patients. So definitely a resource to look at, books that you can be providing to your patients essentially for free. Your organization can receive them for free. And then lastly, as Rhea was referencing, there are a variety of tech nonprofits. It's a growing industry that we're very excited about. When we started CareMessage in 2013, there was maybe a handful of us, and now there's an accelerator called Fast Forward. ffwd.org is how you can find them. And they have a directory you can go to just see a variety of tech nonprofits that offer everything from resources for people who have incarcerated family members, tackling a variety of the needs that your patients have, and those resources being available nationally and online. And so we definitely recommend visiting Fast Forward or ffwd.org to get familiar with some of the resources that are out there that you might be able to reference and provide to your patients and community members as well. And so with that, we're moving over to the Q&A, and I see a few questions. Rhea, I'll read some out for you that are in here. Going from the top, there's a question from Anu. Did the patients in your research mention how they reached out to for assistance? Was it through the clinics they get medical care for, or through their friends or family?
Yes. So usually it was through their friends or family or through an independent search that they did. One person talked about hearing about a resource through their doctor, but I think it came up accidentally because she was just chatting with the nurse, and then somehow the nurse figured it out that she was in need of something and just recommended something to her.
Then there was a question, which I guess is maybe for the audience from Margaret. Has anyone utilized a link to a red cap survey or anything of the sorts to ask multiple barrier questions? I think the chat might be open if people want to send any answers in. We on the CareMessage side have definitely seen our customers send out links to longer surveys. And we've had a few customers also test out using a text-based survey through CareMessage. We do have the ability to send text-based surveys through CareMessage, as well as customized answers to either send resources immediately as a patient is answering, or direct them to resources. But if others have thoughts, feel free to share them in the chat. The next question from Victoria: can you explain the process of selling plasma? Will it lead to long-term health problems?
Yeah, so for the participants who mentioned it, usually they have to go to a specialty location that extracts plasma or blood. And what's challenging is that a lot of times these specialty locations are actually very far away. So they do have to spend a considerable amount of money and time just to even get to these locations. And then so they donate their plasma and they are paid, I believe he mentioned he was paid $90 every time that he goes. As far as I know, and I'm not a medical expert on this, I don't think it has long-term health problems as long as you are a healthy adult who is always passing the qualifications. And as long as you address the risks, it's not too bad. But he feels more like he's forced to do it, even if he doesn't really want to.
All right, I see some questions. Will the slides from the presentation be emailed? We'll send the resources after, because I think there's also a question around the links for the resources and information. We will follow up with all of you with the link to the webinar, the report, the full report, the PDF, and we'll include some version of the slides. Likely will not have the reference to the videos for the participants, but we can send a summary as well. Question from Erica. Thank you for walking through this presentation. In regards to mental load poverty, were you able to uncover or understand whether it compounded existing health issues? For example, patient with chronic condition experiences exacerbated symptoms or flare-ups as a result.
Yeah, so we didn't talk about it in this project specifically, but there's different research studies. There's also a book called Scarcity out there that's a really good read about this sort of mental load. But one of the biggest things that poverty leads to is stress. And stress has been proven to be really bad for your health. It leads to less of an immune response, and it makes you more susceptible to chronic and short-term diseases. Another reason why the mental load could be harmful is maybe you forget to pick up your medications, or maybe you forget to take medications. So it leads to different types of behavior that also is bad for your long-term health.
Let's see. Another comment from Anu. Excellent research, Rhea. Looks like we have to include SDOH needs every time we interact with patients. It's so difficult to listen to these patients going through so much and feel not enough help and support is available to them.
Yeah, so I think it is definitely difficult to hear their stories as well, but I encourage you to just think about every little bit helps, even if it just means that for the rest of this month, they have enough to eat. It is better than them having to struggle for this month and next month as well.
Second question, another question from Erica. You mentioned that staff that works with this population should aim to address stigma and scarcity mentality. How do you recommend clinical staff address this? What is the trust building process for that?
That's a great question. Maybe if other people have suggestions, you can throw it in the chat. But I think one of the biggest things is to be able to talk about it openly and just asking your patients, hey, are you in need of X, Y, and Z? We can offer it to you. And building that trust really requires that you understand what is the level of comfort they have with discussing that. So if they only want to discuss it in private, then you start there. But maybe down the line, they would feel more comfortable just like discussing it with you when they come to the front desk and just asking, hey, like, do you know if, let's say, grocery pickups are available this week? And is it something that I can sign up for?
All right, I see one more. In your research, did you find that patients sometimes could not find resources for their specific situations? What solutions could we provide as providers?
Yeah, I think it actually came up a lot. And I think if we stick within the medical clinic context, it could be really hard because a lot of people may not be going to the clinic the same time they have a need. So if we think about expanding the publicizing the resources outside of the medical environment and maybe putting up flyers in grocery stores or community centers, it can help people discover these resources without having to come in to see their doctor.
This is, for me, I'll just share very briefly. When Rhea was sharing her findings internally, this was one of those like light bulb moments for me, especially with that patient that mentioned, paying their gas bill for heat in the winter. A lot of times the ways that we've seen screeners be standardized, it's, somewhat generic, and it's like the same screener you're sending throughout the entire year. But there could be scenarios or maybe a change in dynamic in the way that we promote resources that might be more timely with seasonality, or even I see it locally a lot. Sometimes, as you're getting to the end of the month, what people realize they're not able to make rent, it's this sort of last minute scramble to try to find a resource to cover rental assistance. And so there may be some other, ways to think about the timing of when information is provided to sort of align it with when, almost trying to predict the needs that patients may have. All right, let's see. We might have time for one last question. I see one coming from Terry. Find it very difficult finding resources for those that are not documented. What do you recommend?
Yeah, so maybe Cecilia is best prepared to answer this, but we do know of some resources that don't require documentation or proof of citizenship.
Yeah, we usually we came across this a lot, during COVID. Particularly, we were seeing a lot more, at least happen through the CareMessage platform in terms of sending out resources. It might take a little bit of digging, but usually we try to find, what has the least barriers and recommend that first. But it's not, at least from what we have found online, not always very obvious in terms of what the community-based organizations or even directories you might find online. They don't always have, something that calls out explicitly if there's something that would require disclosure from the patient's perspective. But going back to some of Rhea's earlier points around the documentation that's required, depending on the types of things that are being required, you can sort of maybe sometimes tell if they're asking for a specific type of ID, like a driver's license, which in some states might not be available to people who are undocumented. Yes, we did rely, I see it was posted in the Q&A from immigrantsrising.org, those resources. Agencies that advocate for the rights of undocumented immigrants can be a really good resource for finding, partners, organizations that they partner with that are oftentimes already vetting for that availability. And Alexia Barajas, who posted on the chat, thank you for sharing those resources. We'll make sure we send those out in the follow-up email. Great. So we're a few minutes past the hour. Thank you all so much again for attending our webinar today. And we'll be following up with the resources with a link to the presentation, the recording as well. And thank you so much for all the work that you do. And we'll see you at our next webinar. Thank you.
Thank you.